Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to be spoon-fed the latest and greatest of emergency medicine. Now, this is the audio version of the past week summaries, which this week were brought to you by our authors Michael Stoker, Samuel Rouleau, and Clay Smith. So let's get straight into the first article, which was titled, Outcomes of Resuscitative Endovascular Balloon Occlusion of the Aorta, REBOA, in severely injured adult trauma patients with isolated thoracic or abdominal trauma in hemorrhagic shock, out of the American Journal of Emergency Medicine. Now, we've talked a fair amount about REBOA in the last little while, and most of it has not been positive. Unfortunately, there's been a whole bunch of REBOA papers that have come out in the last couple of years that just don't seem to show that it's helping people, and if anything, some of the results show that it's harming people. In theory, it should work pretty well, but in practice, it seems to be very difficult to implement. Actually getting a balloon up there, cutting things off, and seeing how that goes. You know, even thoracotomies, it's not the clamping the aorta part that tends to save people. Usually the best thing for saving people with the thoracotomy is that they have a pericardial effusion and that you can get rid of it in a pinch. The clamping the aorta part, that's difficult. And a lot of the REBOA data, well, it doesn't really get into the nitty-gritty details. They don't really talk about the different types of REBOA. Is it a partial REBOA, a complete REBOA, and then what about zone placement? We're still missing a lot of details. These authors did a study on retrospective data from a huge, large national data set with hundreds of trauma centers, over 800 trauma centers. And then they retrospectively looked at this and picked out the patients that had REBOA performed and looked at their outcomes. Huge trials like this, great for generalizability, but it doesn't necessarily show REBOA as the best it can be. You know, if one center does a lot of cases, they get better at it, especially for procedures like this, and that can make a big difference. Look at the ECMO data. It really matters who's doing what with some of these very technical procedures. But anyways, these were emergency department patients and they wanted to know about 24-hour mortality because, that's usually what we want to know about. They had a total of almost 30,000 patients who met their inclusion criteria, and less than 1%, only almost 250 patients got REBOA. And unfortunately, REBOA was associated with a significant increased odds of mortality and adjusted odds ratio of 15, which was significant. And it was not associated with any benefit in any of the subgroups either. Indeed, you actually transfuse these patients more. And it was even worse if it was at a level 2 trauma center instead of a level 1 trauma center, presumably because they do this procedure less. Now, this all ties into that this is very limited data. This is retrospective data. These patients were not randomized to get a REBOA. And nobody's putting REBOA in someone that looks great, So it's very biased here. We would expect these patients to probably have higher mortality rates. And can you say it's truly the REBOA? It's hard to say in these circumstances. You can control for as much as you can, but if you're not at the bedside and it's not clear why these patients got REBOAs, then we're just never going to get down to it. So studies like this, while they're not, positive towards REBOA, you can't throw the baby out with the bathwater. We're seeing how rarely REBOAs are being done, less than 1% of these major trauma cases. And so there's got to be something about the case that made the doctor, the physician in charge, decide to do REBOA. And I guarantee it wasn't because they looked awesome. So, while this is still a little bit disparaging towards REBOA, I wouldn't hang my hat on it. And these patients, whether it was blunt trauma or penetrating trauma, whether it was zone 1 or zone 3, all of them did not fare very well. In a spoonful, the use of REBOA is not associated with better outcomes, at least in retrospective studies, but it's also probably not associated with less sick patients. And then we skip to the fifth and final article, titled Red Cell Transfusion in Acute Myocardial Infarction, the AABB International Clinical Practice Guidelines, out of the Annals of Internal Medicine. Now, we've actually had 4 total trials now looking at whether or not you should transfuse patients who are below certain thresholds if they're having an acute myocardial infarction. This counts for type 1 and type 2 STEMIs. You just have to reach the guidelines, depending on the study, it was the 3rd or 4th universal guidelines or definitions for MI. But either way, they're having an MI. What should their hemoglobin level be for you to think, hey, I should transfuse this person? And this matters because up to 40% of elderly patients who have an MI are also anemic. And some of these studies seem to show that there might be a mortality benefit, and we tend to care about mortality benefits. And all of this makes sense, okay? The heart uses a lot of oxygen. When it's ischemic, it's not getting enough oxygen. If you can put more hemoglobin in there, then it's not that hard to make a kind of hand-waving explanation why this might make sense, and it could save cardiac tissue, which then could save lives. This, of course, is weighed against the risk of transfusion reactions and circulatory overload, which can cause things like pulmonary edema. Now, the 2 biggest trials, which we covered on the JournalFeed before, are the MINT and REALITY trials. These are RCTs which looked at these questions, but the results of the 2 didn't exactly agree with each other that well. So these authors put all the data together, and they came up with the recommendation that for hospitalized patients with an acute myocardial infarction, the international panel suggests that red blood cells should be transfused if the hemoglobin is less than 10 grams per deciliter. This is a conditional recommendation with low certainty evidence. And the authors are very clear that you should be very cautious about this. In patients who already have pulmonary edema, you don't want to necessarily just go straight bang into giving them PRBCs. You might want to diurese them first, improve that condition, and then consider transfusing. If the patient is really hard to cross-match, then not necessarily that patient. So you still have to pick patient by patient, but they're still making this recommendation. When they meta-analyzed the 4 trials, though, it gave a 30-day mortality risk ratio of 0.87, but that was not statistically significant. So I find it interesting that they still made this recommendation to transfuse anyways. The difference did meet their threshold for a minimal important difference of 1% in the mortality rate at 30 days, but it wasn't necessarily a significant difference, so I'm impressed that they still made this recommendation. A number needed to treat of 84, which is pretty big. Honestly, though, this would be practice changing, but make sure you check with your hospital policies and your blood bank to make sure that you can actually meet the demands that this would put on the system. This would be a lot more patients getting a lot more transfusions, and we're not entirely sure how that would affect the rest of their hospital stays. This was NSTEMIs, by the way. All right, in a spoonful, this was an official recommendation to target a hemoglobin level over 10 in the context of an acute myocardial infarction. All right, that's all the articles from this week. Let's do a quick wrap-up of everything we talked about. From the first article, this was another blow against REBOA. This enormous retrospective trial showed harm, but it was retrospective. And then from the 5th article, kind of a practice changer here. This is guidelines recommending transfusing to a limit of 10 for all patients with acute myocardial infarctions. Now, if you are hearing this right now, then you are not a part of the members feed. And so you missed 3 articles from this past week. What did we talk about that you missed? Well, we talked about the STAMP score, which might help you decide what to do with higher risk PE patients. And then we talked about nitazines. Have you heard that word before? Well, they're a new synthetic opioid. If you want to find out more, you got to become a member. And lastly, we talked about platelet transfusion thresholds, new guidelines, something that you probably need to know about. Links to all the original articles can be found at journalfeed.org, or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.